Good evening, everybody. I'm Dr. Konstantinos Triantafyllou from Athens, Greece, and it's a great pleasure for me to welcome you to another EAG webinar. Today, we have an excellent panelist. We have Professor Lars Aabakken from Oslo, Norway, and we'll discuss a very fascinating topic. It's about how do I get into the bile duct. As you already know, it is the third consecutive year that EAG offers you the opportunity to view high-quality presentation on the hottest topics from world leaders in endoscopy. And also, you have the opportunity to interact with them and to participate by submitting online questions. And of course, it is free for everybody. And please, during this webinar, use the question and answer function. You can find the button at the bottom of your screen. Send me the questions during the presentation of Lars's presentation, and I group the question, and at the end of our webinar, we have time for discussion and to answer your questions. And now it's a great pleasure for me to introduce Lars Aabakken. Professor Aabakken is one of the leaders in endoscopy. It's an excellent teacher as well. He has produced tutoring videos. He is a teacher of many endoscopies worldwide, and he's an expert in ERCP and endoscopic ultrasound. And so we could hardly find someone more proficient to address this issue, this difficult issue, and very fascinating as well, of how I get in the bile duct. So Professor Aabakken, dear Lars, thank you for being with us, and looking forward to watch what will you teach us. Thank you. Thank you for being with us.
Well, thank you, Kostas, and thank you for inviting me. As some of you may know, Kostas is the spearhead and the brain behind the whole webinar initiative of ESG, which has been running for quite some time now. And I think the COVID pandemic, although a problem in many ways, highlighted the foresight of Kostas to establish this platform even before the coronavirus came along. So I was tasked with just explaining a little bit about how I do get into the bile duct myself, and so I'll try to do that. So as you know, once you're at the papilla, this is what you like to do. So you hit the orifice, you slide inside with the tip of the catheter, you pass the wire, and you realize it's passing in the direction of the bile duct. So in this situation, it's easy to be a ERCPist. Unfortunately, as you all know, this is not always the case, and I will try to explain some of the issues which may arise, and particularly how I deal with cannulation when it's not like this. So why do we urge for this cannulation success? It's you know, the holy grail of all novel ERCP trainees. Obviously, you have to cannulate to be able to finish the procedure successfully. Procedures will be quicker because what usually takes the most time in difficult cases is to get inside the bile duct. We think that cumbersome cannulations or even failed cannulations will cause more complications, which we don't want. And obviously the self-esteem will improve as well. Now, I think it's important before we sort of go into the cannulation techniques to agree how to define success, because I think that particularly for research and for reporting your results, it's I think we need to understand this term. So the success is obviously relative to what you try to achieve. So in many cases, biliary opacification is part of the success, but mostly you want deep cannulation for most purposes, and for all therapeutic purposes, you want deep cannulation with a catheter. So just showing the bile duct is rarely defined as success. And also pancreatic cannulation is sometimes indicated, sometimes needed, sometimes inadvertent, and sometimes blatantly wrong. And even if you get into the bile duct or the desired duct, the therapeutic goal is another element of your success. So cannulation, if you're not able to get the stone out, can hardly be defined as a successful ERCP, although the cannulation succeeded. I wanted to start with the beginning, and I'm sure some of you are already experts, and for those, these are obvious elements, but I would mention it anyway, because when you start doing ERCP, I think even before cannulating, you may get in trouble with navigating your side viewing endoscope. So the first thing, which may be a difficult thing, is that you don't have your normal visualization of the larynx, and so finding your way may be more difficult, although the rounded tip of the scope is usually more easy to pass. And so if it doesn't slide easily, you should try to visualize what you can, because that will help you stay in the midline. It will tell you what level you're in, and most of the time it's helpful, even though the visualization is less and different from what you're used to. If you cannot slide, sometimes having somebody give the patient a jaw lift will help. And if it's struggle, if you're pushing and don't get anywhere, I would normally pass a wire or a catheter over a wire, something I would use anyway, and by visual control pass that in the midline into the esophagus, and then go behind that into the esophagus. I think that helps the actual passage, and it feels a lot safer than just pushing blindly on the on the larynx. Also, I think in the beginning, a lot of people get lost in the stomach, and typically what you see is only parts of the fundus of the stomach, and you don't really understand where to go. And you don't really want to insufflate too much air, because it's uncomfortable for the patient, and it makes passage into the duodenum more difficult. So you can get lost in this situation. And if you do, the number one trick is to pull back all the way to the cardia, and then remember that very similar to how you sort of navigate your straightforward, your forward viewing scope, you should turn right and tip up. And then you obviously have to slide along the graded curve onto the pylorus. What can cause problems is cascade anatomy, because in that case, the sort of orifice to the distal part of the stomach is really high up, and you may very well miss it and just slide into a big fundic proximal body part. So that may be difficult, and also large hiatal hernias may cause at least some confusion in the beginning. I think if you're struggling like this, X-ray may help you to understand where you are. And sometimes you can see the pylorus, you see where you need to go, but you're just not able to get there. Your sort of scope instead loops back into the body, or you don't have enough push to get through the pylorus. If that's the case, I usually put the patient in the left-sided, left lateral position, or even supine. I think that sometimes helps. We usually have the patient semi-prone, which is my my preferred positioning of the patient. But if this is a problem, then my number one trick is to put them on the left side. And if I do that, I would put that in the report as well, because next time we have the same patient, usually we would use the same trick, and then we could start like that. If that doesn't work, I would pass a catheter or a guide wire into the duodenum, because that helps sort of steer the scope through the pylorus. And if you're struggling anyway, my sort of last step of this would be to take a large caliber dilation balloon, like a 20 millimeter colonic balloon, over a guide wire with X-ray control, deep into the duodenum as like an extension of the scope. So it's not for dilation, it's for anchoring and steering the scope even more. You just have to deflate that balloon as soon as you get into the second part of the duodenum, and gradually pull it back. sometimes you end up with an alpha loop in the stomach and you may not be aware. You're just pushing scope more than usual, and then in the end you get to the pylorus, but you feel something is wrong because you spent more scope than normal. And when you do look at the x-ray, you will see that there is an alpha loop in the stomach. And the trick then is that if you try to straighten your scope the normal way by twisting right and pulling back, you'll fall back into the stomach very easily. So in this situation, you should go deep into the duodenum towards ligament of trice, and then pull back very slowly, and very often, depending a little bit on the alpha loop, you may need to rotate counterclockwise, the opposite of what you're used to doing. And having the X-ray image to understand what's happening is quite helpful in this situation. Okay, getting to the papilla also is different if you have surgically altered anatomy. I will come into that a little bit at the end, but that's obviously a different story altogether. Now, as you are well aware, papillas are positioned differently and they look differently. And so what you have to start by doing is to inspect and to try to make up your mind about where the orifice is before you poke at it at all. Spend some time watching it and spend then some more time getting into the perfect position.
Lars, may I interrupt you? Yeah, you clearly highlighted the different type of papillas, and recently there is a publication from Scandinavia team that we should not only inspect the papilla in order to find the way in the bile duct, but the morphology of the papilla might predict the difficulty of cannulation. So yes, there are at least 4 types of papillas. I don't know if you would like to comment this time or you go further.
No, I mean, we can do that. I think a couple of teams have tried to make categories of papillas to exactly as you say, to help predict which ones are difficult and maybe even what method to use. I think at the moment we still struggle to find a sort of a unified vocabulary and a reasonable categorization, which predictably can tell us how the papilla will work. And I think we all, after years of ERCP, realize that something which looks simple may just be hard, and some things which may look difficult, like tiny papillas, may be very easy. So I think the predictability based on appearance is a relative thing, but obviously you should observe it. The appearance of the papilla also is a important factor about how you deal with cutting it, and you should ideally look at it before you have anything inside, because that's your sort of native anatomy, and it tells you, for example, how far your sphincterotomy cut can be.
Thank you, Lars. Thanks.
Okay, so my big hero, Peter Cotton, usually says that the 3 keys to ERCP is position, position, position. And for sure, positioning is important. And these are the elements that I would like to go through in a little bit more detail. And the first thing is what I call retained access, because not infrequently you deal with papillas which have been treated before. So there is something inside, for example, a stent. And if there is a stent inside, then I would usually cannulate alongside it. If it's a 10 French stent, it's difficult because then you will may need to take the scope out to get the stent out. And pulling a 10 French stent through the scope can be done, but with a wire inside, it's difficult. So in that situation, it's not as relevant. But if you have a 7 or 8.5 French stent, then cannulating alongside it, I think, is usually as easy or easier than a freehand cannulation. And then after the wire is in place, then you can pull the stent out. If you have more than one stent in place, I would remove all except one and then do the alongside stent cannulation. If you have a stent which has been placed in a very difficult position inside the liver, you might really want to sort of maintain that access. And if that's through a stricture, then passing a wire alongside it may be very difficult. So if that's the case, then I sometimes use the trick which I will show you here. So this was a patient who had 2 stents for quite some time. And it was exactly like that. They were deep inside the liver of a patient with with complex intrahepatic strictures, and I did not want to lose that access because we had struggled a long time to get there. So what I do then is to grab one stent with a snare as normal. Try to avoid grabbing it just at the sort of hole of the flap, because if the stent has been for a long time, it may break when you try to pull it. And then after that stent is gone, instead of cannulating alongside, I cannulate the stent itself with a sphincterotome, which is usually not that difficult. You can even do this with pigtail stents, which makes it a little bit more tricky, but you can do it with them as well. And so you pass the wire deep into the liver through the whole stent, and then you take the catheter out, leave the wire, and then you take a snare over that wire. So you pass it, open it a little bit, pass it over the wire like this, and then you open the snare and grab the stent over that wire. So this takes a little bit of dexterity, and you have to be careful not to push the stent inadvertently into the bile duct. But if you're able to do this, then you just grab the stent just at the tip, and then you tell your nurse to hold it really firmly. She will not be able to compress it onto the wire, so that's fine. She just needs to grab it enough so she doesn't lose it. And then you have to straighten your elevator, of course. And then if you stay close to the papilla now, so you don't lose your access when the stent flips out, then by the time your stent is out, you end up with a wire through your stricture automatically. So in that particular situation, it's worth the little extra struggle to do it in this way. Now, about positioning. It's obviously easier to work on a papilla when you're close by, but sometimes that gives you an angle which is too far down, and you are also not able to utilize the angulation of the sphincterotome. So you have to balance those issues. Sometimes you have to sort of hook your catheter or whatever tool you're using into the papilla first, and then push your scope while maintaining your position by pushing your catheter into a deeper position, because then you get the direction that you need. This is, not that critical for with a sphincterotome, because you can use the bending of the sphincterotome to get inside. But for example, if you want to use a biopsy forceps or something else which is stiff, then this is exactly how you get into the papilla. You enter it close, and then you push yourself deeper to get more distance and a better direction. Second, if you're struggling and not getting inside, a semi-long scope position is sometimes helpful. So you are on top of the papilla, and then you push inside. Sometimes you just push yourself onto the ligament of Treis, and then it's not helpful, but not infrequently you sort of go down a little and then you come back up again, and then you can approach the papilla with a different angle. And also just the sort of mechanical modification of the duodenum may change the intraduodenal part of the bile duct a little bit to facilitate cannulation. And if you're struggling for a long time, sometimes you can get a good position by going back to the stomach and try once more, sucking out the air from the stomach. And I think also that flushing with Simeticon, if you have a lot of bubbles, is sometimes quite useful. And Buscopan is also on occasion useful if you have a lot of movement and you need delicate maneuvering. Then Buscopan, I think, is a reasonable thing to do. It has been a debate for some time whether to understand where you are by a wire or by the direction of the wire or contrast. And a number of meta-analyses show that wire-guided cannulation is more effective and safer. And so this is almost true. I think some of the big heroes of ERCP have sort of a twist to this. So if they're not getting inside easily, they would squirt just a tiny bit of contrast, not filling the pancreatic duct or bile duct at all, but just squirt a little bit to understand a little bit better the anatomy of the intraduodenal part of the distal duct. And I think that little squirt of contrast is not likely to harm the pancreas in any way. So if you're struggling, that may be worth its while, at least according to some of our friend experts. Now you can cannulate with a catheter, but I think increasingly most people would at this time use a sphincterotome because of the improved angulation it offers, so that you get your direction. With a straight catheter, you're more likely to end in the pancreas or not get in at all. You can also use a bowing with rotation to get an extra angle of freedom. Most people would do a sphincterotomy as a part of their therapeutic ERCP, I think. And so then you have a direct access to that and you don't need to change tools. And also sometimes when you want segmental cannulation inside the liver, then the intraductal bending of your catheter can help you access segmental ducts, which are otherwise difficult to get to. But the navigation is a little bit more complex, and in some cases the stiff bowed tip may pose a problem. One example is patients with PSC, which sometimes has this retraction of the papilla into a crevice, and so in that situation the bending of the sphincterotome will be a problem because you end up in sort of the roof of the papilla instead of in the direction of the duct that you want. And if that's the case, you should take your sphincterotome out and straighten it completely. And also, if you want to access the pancreas, then again the bowing is usually not helpful and sometimes may be harmful. And so in that case, you might consider just using a straight normal cannulation catheter. This is just to show you that if your papilla is sitting way down, like in this case, that was not the papilla, although it looked like it because the papilla is down there. In this case, you would never get into the papilla with a straight catheter because I was not able to get further down. So in this case, you can do this sort of from a distance bowing, and with that, get the access angle that you need. There's some debate about what kind of wire to use. I think I use a straight wire. For me, that's the most logical thing. Some people prefer a angle tip wire. I think that's personal preference. For a while, we had this loop tip catheter from, or sort of, it's a guide wire, but it was used as a catheter from Cook, which in theory should avoid getting stuck in the crevices of a papilla. I'm not sure if it's available anymore, but it was sometimes useful for cannulation, but not for other purposes. As you all know, you not infrequently end up in the pancreas when you want to be in the bile duct. And so my best tip is to utilize it. If you get into the pancreatic duct at once, then I would pull back out and try again with the bile duct. But if you have been struggling for a while and then get your pancreas, then I would keep that wire and utilize that in one of several ways to access the bile duct. And the most frequently used technique, I think, is what's called the double wire technique, which sort of is reflecting how the anatomy of the papilla is, with these 3 sphincters and the sort of combined anatomy of the 2 ducts. So the idea is that the wire in the pancreas will stabilize the papilla. It will lift it more towards the working channel of your endoscope, and it will straighten, obviously, the pancreatic duct, but also the common channel, which means it will also straighten the bile duct. And to some degree, it will block the pancreatic duct, although sometimes it doesn't really block it. And when you try to go alongside it with a catheter, you just go along the wire and cannulate the pancreatic duct with the next wire as well. And if that happens, then you should stop and change your strategy, because then your wire is not helping you. It's making problems. Yeah, but so the principle is like this: you keep your wire in the pancreas and you go alongside with usually a sphincterotomy, and this is how you can do that. Sometimes the orifice of the papilla is small, and then it's a little bit difficult to get alongside the wire which is already there. But the idea is to try to get on top of your wire, and with a little bit of bowing the sphincterotomy, aim more in the bile duct direction. And at least for me, surprisingly often, this is exactly what you need. And so this is by far my #1 method of sort of problem solving if I have pancreatic access and don't get into the bile duct. There has been some recent reports indicating that this may in fact increase the risk of pancreatitis, but I think that's a little bit like blaming precuts for pancreatitis. If you have a problem solving modality, then it's probably the problems and not the sort of the final solution, which is the real problem. So I'm not so sure that's true, because if you, I mean, it may be harmful to have a wire in the pancreas, but the wire is already there, and that's why you can use it. So whether the double wire technique itself is the problem, I'm not so sure, and it's for sure effective. I think I'll skip that, but this, if you have that wire access, instead of using the double wire technique, the other version would be to place a stent in the pancreas and then do a needle knife sphincterotomy over that stent. That makes things a lot safer and more sort of directed. You have a cut which is more likely to end up in a good place, like you can see here. So that's an alternative to doing the double wire technique. And I think if your double wire technique does not work, I think this would be my sort of next step, because then, as I said, you already have your wire in the pancreas, so placing a small pancreatic stent is easily done, and then you have sort of another modality to try. This is what we also not infrequently do if the double wire technique does not work. So in this case, we tried the double wire technique here and we failed. We were not able to get into the bile duct anyway. So after some struggling with that, I went over that pancreatic wire again and then did a complete sphincterotomy over that wire, so into the pancreas. But as you know, there is a common channel at the end with a common sphincter. And so the idea is that by this, although you're cutting the pancreatic orifice, you're also cutting the maybe most difficult part of the bile duct. And the other utility here is that when you see the groove of your cut going into the pancreas, you know that almost always your orifice to the bile duct is on the left side. So orienting yourself in the cut is not always easy, but here you can look on this side. And I think if you look closely, you can see the orifice right there. And after a little bit of tampering with it, I put the tip of the guide wire out a little bit, and then with the right direction, like so, I was able to slip inside. So I think the main utility of this compared to a freehand cut is that you know more about where to look for your biliary orifice. Sometimes you don't see it like this, sometimes you don't get in, and then you can make another needle knife cut transversely on your first cut to the left. But again, you have more control of your cutting than with a freehand. So We have been doing a multi-center study in the Scandinavian group of research for endoscopy, where we compared this to the double wire technique, and particularly the group from Helsinki in Finland are very much fans of this technique as opposed to the double wire technique, and it may be that it's even more successful and with less complications. We don't quite know yet, and this is not a completely agreed upon technique. And I think, for example, in the States, they're very careful about this and very worried about doing pancreatic sphincterotomies. But there are some studies indicating that this at least is better than needle knife sphincterotomy, as you can see here. But sometimes you don't get into any duct, of course, and then you don't really have any other options. If you want to proceed with the procedure, I think one very valid option is to stop or call a friend or try another day. But if you need to get inside, and sometimes you do, then you would need to do a sort of a freehand pre-cut, which is not a trivial thing. This is one of the meta-analysis showing the problem, the number of complications. I think this varies a lot, obviously. Oops. Something has disappeared there. But this frame really just showed the variability here, and I think that depends mostly on the expertise of the operator. So some do this all the time, get very good at it and very confident. I think what you should not do is to use freehand pre-cutting as a solution for poor cannulation technique. So before you do your pre-cut, you should make some considerations. You need to look at the anatomy of the papilla, because this decides in many ways how you will design your cutting. The experience of the operator obviously is a concern, so this is where you should really call a friend, if not to take over the procedure, at least to join you for your pre-cutting, at least in the initial phase. You should also consider why you're failing, because sometimes it's a difficult papilla, but there may be other reasons why you're failing, like an uneasy patient or other things which will not be solved by pre-cutting. So I think that's also something to consider. And like I mentioned, the indication and the urgency for the ERCP, because sometimes it's better to stop. So all of those things should be considered before you decide to go for a freehand pre-cut. But then the idea is to unroof this part of the papillary substance and to aim in what you think is the direction of the bile duct, which is usually at 11 o'clock. And then there are basically two principal versions of the papillotome. One is the normal needle knife, which I think is the most frequent one. And then it's the sort of so-called 0-20 papillotome, which is, I think, more popular in Germany. So the technique is to, at least what I do is I aim for the orifice and then I cut cephalad, layer by layer, trying to stay, understanding an anatomy and trying to stay in 11 o'clock position relative to the direction of the duodenum. Some people prefer to cut in the distal direction. I'm not quite sure about the logic for that. For me, it's easier to start at the orifice because I know the bile duct is at least there. And then before you start cutting, you should have another look at your anatomy to understand how far you should cut. Similar to a normal sphincterotomy, you should not go beyond the bulge of the papillas, and that means that the amount of cutting you can do varies a lot with the anatomy of the papilla. In some cases, it's very easy to do this. For example, if you have an impacted stone like this, sometimes you can see it, sometimes you cannot see it, but you know it's there because you can palpate it. And if that's the case, you can just cut onto it like you would cut onto a stent, and it's a very gratifying procedure indeed. So that's very sweet, but unfortunately not all that common. And impacted stones like that are often very small, not like this. So this is with the 0-20 papillotome, where you also start in the sort of the orifice. You sort of duck into the orifice as far as you can, and then you do your cutting in the 11 o'clock direction. I don't have any major experience with this myself, but in some units I know they prefer this particular tool. This is what we usually do, the normal freehand cutting. So starting at the bottom and then cut. I usually do some pre-runs with my elevator and wheels to understand how my needle knife will move once I start cutting, because you want to see how that works before you actually cut. And then you cut little by little, and you stop to have a look to see how things are. But you have to cut enough for things to open up a little bit, otherwise it will be very difficult to understand your anatomy once you start poking. So you do this sort of serial sequential cutting, and you probe a little bit, and then sometimes your orifice is very obvious, and then you can have a guide wire in your needle knife and pass that directly. Otherwise, at this point, we usually change to a to a normal sphincterotome and then start probing in your cut. And sometimes after cutting like this, you don't get in, you have to cut a little bit more. Just be careful and look for the structures which indicate that you have the bile duct there. And this may be easy, but it's typically not, and it takes a little bit of experience to understand the anatomy inside such a cut. And sometimes, even after cutting like this, and even if you see bile, you're not able to find the orifice. And particularly in the beginning, that may be the case. And then again, I think you should consider stopping as opposed to continuing to cut, because the more you continue, the more you risk a perforation. And sometimes taking this patient back after 2 or 3 days is a good idea, because then things have calmed down, the edema is gone, and the orifice may be very easy to locate. Yeah, so I think I've been through most of these things, ways to reduce the risk of pre-cut, which is, like I said, potentially a dangerous procedure. Another option is what's called fistulotomy, and I would just like to mention this little paper because it's the first paper I ever published back in 1986, and this was for ampullary cancers, where we made or not we, but my boss, Dr. Osnes, made a fistula on the bulging dilated bile duct. But it has been argued that instead of doing a normal pre-cut, if you have a dilated duct, then a fistulotomy is safer, because you stay away from the pancreatic duct and so reduce the risk of pancreatitis. But this obviously mandates that you do have a bulging of the bile duct so that you know where to make your fistula. Yeah. There are some special situations that I would just mention to you. One is papillas inside the diverticulum. That's always a kind of surprise you don't want to have. You think you're having a super easy ERCP, and then you come down and see a big diverticulum. And sometimes it's just on the edge and you can still see it. Sometimes you don't really see the orifice at all because it's inside. It's usually at 5 o'clock or 7 o'clock. Sometimes you can see the ridge inside the papilla, inside the diverticulum, and then you would look for the orifice there. Sometimes you're able to get your scope tip inside, depending on the size of the neck of the diverticulum, of course. Sometimes you can use a balloon dilator. You can pass a baby biopsy forceps next to your cannulating catheter, and that can also sometimes be helpful to invert the edge of the diverticulum. You can inject saline, similar to how you visualize polyps by injecting distal to them. And sometimes placing clips on the edge can also help you. But I think I would advise, before you start doing these things, you should really have a very clear idea where you will be finding the papilla inside. If you find the papilla and you're able to get a guide wire inside and you go to the pancreas, this is a #1 reason not to let go of that pancreatic access, because that wire for sure will help you get into the bile duct as well. So please keep that, or place a stent. I think primarily keep the wire. This is, I think, showing a slightly different issue. So you can see the ridge in the middle here, but you don't really see, whoops, you don't really see the papilla. So we're looking around. We think it's on this, but we don't really know for sure. So we looked here and we looked there. But as you will see in a moment, because we saw some bile coming, the papilla is on that ridge, but it's on the side. So it's pointing to the right. And so even though we saw it there, it's still a little bit difficult to access. So we had to put the tip of the catheter inside the sphincterotome and then sort of flip it up. And once we had that done, then getting the access was not all that difficult. But you have to spend some time. Sometimes the diverticulum is filled with debris or food, and then you obviously have to clear that out first. But most of the time, the papilla, I think, would be found at 7 o'clock or 5 o'clock position. So that's where you would start looking. If you do get inside, please worry a little bit about your sphincterotomy, because I think you have, your anatomy is different, and probably your space for doing a sphincterotomy is oftentimes less. So you would rather do a more moderate sphincterotomy and dilate your orifice as opposed to doing a full-size sphincterotomy inside a diverticulum. The other situation I just wanted to mention is Billroth 2 anatomy, which is becoming more rare, but we see it. We usually use a duodenoscope in those cases. At least try with a duodenoscope because of the improved situation once you find the papilla. And then we change to a enteroscope if we're not able to get there. So how to get inside? How everything is upside down, as you know. So papilla is there, but it's going in this direction to the bile duct. So your normal sphincterotome will not work. So what you can do is to twist it around 180 degrees. That's sometimes quite difficult. And once you're doing all that rotation, it doesn't really work so well. So although this illustration shows that technique, we don't really do that much. We try with a straight catheter. We impact the papilla and then we sort of bend the catheter in the direction of the bile duct. I think you can maybe see that in a moment. So this is the papilla here, and a straight catheter is better in this case than a sphincterotome. So we don't use a sphincterotome. We use a catheter and then we change to a sphincterotome later on. And for sphincterotomy, this is what we usually do. So we place a temporary 7 French stent, and then we use a needle knife to cut onto that stent to perform the sphincterotomy. Because usually that's quite easy to do. Placing the stent takes another minute or so. And after the cutting, we just extract the stent with a snare and then continue. But this, to me, is you get a very good visualization, as you can see, and the orifice tends to be even a little bit bigger than you think. So I would suggest this method for sphincterotomy in Billroth 2 patients. What we also see on occasion, as you know, is gastric bypass patients with gallstones. So in this case, we use a balloon endoscope, of course. And let's see if this, yeah. Okay, so this is what you want things to look like. The scope was in the stomach, and then you pull back through the duodenum looking for the papilla, which is up here, and the channel is here, so you have to rotate things to get to it, as you can tell. So you try to rotate your scope, and like so. And then nowadays, this is an old video, but nowadays we use a cap, which helps us sort of flip the papilla in your direction. But this is the kind of struggle you would have with a forward viewing scope with a Billroth 2 anatomy as well, and the reason why we always try with the duodenal scope first. But otherwise, we just try to flip the orifice in the right direction. And for sphincterotomy, in these cases, what we do is we leave a wire inside, and then we pass a needle knife alongside the wire into the papilla and then cut outwards towards the lumen, as you can see here. And that's a little bit cumbersome, and your cut is not very effective usually, but you can do some cutting, and then we do balloon dilation, thinking that the disruption caused by the balloon will now follow the direction of our sort of initial cut, and so will be safer than just dilating directly. So this would be the technique in gastric bypass, and also in patients with gastric resections, which have a very similar type of position. So summing up, when everything fails, because it sometimes does, you're supposed to succeed more than 90% of the times, but it means you still fail sometimes, and everybody fails on occasion. And these are all your options, and you should have those options in mind even before you start, so that you have your strategies lined up to what to do. Otherwise, you may tend to persist too long. Having options makes you make a change more sooner, which I think is quite reasonable. Increasingly, EUS supported access is becoming an option, primarily for dilated bile ducts, but that's often the case, of course. And it also requires EUS competence as well. But again, your expert ERCPists increasingly have EUS competence as well. So those options, I think, increasingly become reasonable alternatives. Otherwise, if you have an excellent radiologist, they can do good things with PTC as well if you are failing yourself. So to conclude, most cannulations are straightforward, but if they're not, you should optimize your situation. You should think sequentially. You should think about, okay, if this fails, then this will be my next plan, and then this will be my next, because you should not persist with the same thing which fails, because it's likely to continue to fail. You should rather have a next idea in your mind, because that will, like I mentioned, will make you change more quickly, which I think is a reasonable thing to do. And weigh your risks, as I said. You should know when to stop, and I should know when to stop too, which would be just about now. Thank you.
So thank you, Lars. Thank you for this very illustrative and very comprehensive presentation. So you clearly highlighted difficulties, you clearly highlight tips, you clearly highlighted tricks, difficult, more not that difficult situation, but as you said from the beginning, ERCP is a challenge, so cannulation is a challenge. No papilla is similar to the other, although they may they look alike, but every ERCP is a different situation. And we are happy to have almost 300 attendees for this webinar, and as expected, we have a lot of questions. So I tried to summarize and group the questions, and let's start from one which I think is a very common issue. So we start the cannulation with the sphincterotomy and the wire, and the papilla looks very, very easy. You dock on the papilla, the sphincterotomy, very nicely. You advance the guide wire. It seems that the guide wire advances a little bit and then it stacks. So the question is why and what I'm doing wrong? Do I push a lot? Is the S shape of the intraduodenal part of the duct any kind of maneuver with the endoscope? So what do you think?
Well, there may be a number of reasons. So basically your guide wire will stop into the crevices of the papilla, usually because it's not slick. It has crevices inside. So that's the number one thing. And if you're able to put the tip of your catheter in a little bit, then you have more support for your wire, so it's easier. But if you're not, then the floppiness of the tip means that the wire very easily will get stuck in the irregularities inside the papilla. And the other thing is, I think what you alluded to, because sometimes your papilla is sort of stuck inside the wall of the duodenum and stable, so you can manipulate it without manipulating too much on the ducts. But sometimes it's not like that. It's more floppy, and so once you start sort of touching it and pushing it with your catheter tip, you are changing the shape and anatomy of the ducts, which makes it, like you say, very S-shaped. And although this straightens out once you're inside, it will certainly constitute a difficulty in terms of how to enter the duct. And sometimes you can see a wire going like this, and then go into the pancreas, which tells you exactly that this is a situation that you have been manipulating and creating, difficulties for yourself by your pushing. So I think the more floppy the papilla, the more careful you should be with the pushing with the tip of your catheter.
Thank you. And another question is that, okay, we start to cannulate, we don't find the way in, and then we try to inject a tiny of the dye to get a better view of the anatomy. And it's our bad luck that we injected it submucosally, and then there is a big bump of the submucosal injection, and what do we do then except to abandon?
Well, I think abandoning is sometimes a good idea because once you have the submucosal injection, that happened because you were already struggling. It was already difficult, and for sure you have added to the difficulty by your submucosal injection. You have formed some level of a false route, and I think you should consider stopping if you have that. But I think also if you get submucosal injection, it usually means either that you've been doing some pre-cutting or that you pushed your catheter very hard and your nurse pushed the contrast quite hard. And so you should try to avoid both things. So submucosal injection is always bad, very often causes you to abandon procedure, and should not be necessary to happen, I think.
Okay, thank you for giving us clues and also helping us to prevent submucosal injection. Yes, I think it's very unlike event. We have some questions. We have a lot of questions about the fistulotomy and the pre-cut and the comparison to the double wire. So we have double wire cannulation and we have freehand cannulation like sphincterotomy or fistulotomy. Which is the preference, or which is the better way to go in the bile duct in case we cannot go there directly?
I think when you read the literature, it's quite confusing because the data which are published are quite conflicting, which is no wonder to me because there's one thing you cannot do in endoscopy clinical trials, even randomized one, and that's to blind the operator. You cannot blind him and you cannot take away his preference and his own expertise. So I think that's one of the reasons why these comparisons should always be read with a little bit of skepticism. And then I think that all these solution techniques are potentially quite effective, and the number one factor is your own expertise in using it. So that's at least I think the most important thing. And then there is, for me at least, there is some hierarchy of risk. So for me, still the double wire technique feels like the less risky thing to do if you already had the wire in the pancreas anyway. And I think freehand pre-cutting is the most risky thing. But that's at least, you know, that's in my hands. I think if you are a surgeon who's, you know, changing to freehand pre-cutting after 2 minutes of not cannulating because you're a busy guy with a lot of balls, then you become an expert on the pre-cutting, and then obviously the risk goes down as well. So I'm not here to say that it's a bad technique, but it's more difficult to master. And it's always, you know, the problem when you talk about these things. Yeah, you should do it, but only if you know how to. And how do you get to that stage without the phase of failing and being a beginner? I think that's a little bit of a dilemma. But like I said, all these are potentially good methods. Comparisons are difficult to read. And being an expert in what you do, the one method that you choose, I think is the number one strategy, a little bit regardless of which one you choose.
Okay, yes, thank you. I totally agree with you, and I'm very happy that you highlighted very, very well that getting with the wire into the pancreatic duct is not a disaster. But taking advantage of that, it can be advantageous on helping you to get in the duct. So
Yes.
another question is about the septotomy. So our colleague asks whether you need to put a pancreatic stent to prevent pancreatitis if you go in the bile duct using septotomy.
Well, to be honest, for me, it is a little bit relative to how much you've been struggling. But I think in principle, because you already have your pancreatic access, placing a pancreatic stent for protection is probably a prudent thing to do. I think, you know, placing pancreatic stents, if you're not already in the pancreas, is a mixed blessing, because sometimes you struggle and you traumatize things more to get that access and place a stent, and maybe you even fail, and then you're sort of double at risk. But I think in these situations, you mostly have already been struggling for a while. You have traumatized the papilla. There will be swelling, and so I think the threshold for placing a protective pancreatic stent should not be too high in this situation.
Thank you, Lars. Again, with the pancreatic insertion, the guide wire to the pancreatic duct. So, okay, you go, you try to get in the bile duct, but you get in the pancreatic duct once or twice. And is there a threshold of times entering the pancreatic duct that will guide you to put a pancreatic stent or I know the data are conflicting, but what is your preference when you decide to put the pancreatic stent?
Well, like you say, it's a little bit difficult to give a number. I think if you go with a wire more than 3 or 4 times in the pancreas, then probably I would put a stent. But I would also mention that most of the data on the utility of pancreatic stents were published prior to the advent of rectal non-steroidals. So how much of an added utility of the pancreatic stents is there when you already have reduced the risk with the NSAIDs? I'm not quite sure. So I think that's data we need to collect, because obviously placing that stent, it's an extra cost and extra time, extra struggle, and the added check that it falls out after a week or 2. So I would be very happy to see new data showing the utility of pancreatic stent, not just in young SOD ladies from America prior to the NSAID era.
Yeah, we also have another option now, the aggressive irrigation
Yep.
with the reduced lactate. So we have many tools, I think. And
Yep.
I think that I will proceed to our final question. It's not a question as some of our guys seems to be experts and would like to have some, I don't know if it's feasible right now, tips and tricks about the minor papilla cannulation.
Are you asking me?
Yeah, yeah.
Oh, okay. Yeah, well, so my tricks would be first to have a semi-long position of the scope. Usually it's the most easy way to get there is to go back into the stomach, push your scope, and then not straighten it. Then you will get your position in front of the minor. If you can see it, it's fine. If you cannot see it, because that's sometimes the case, we would spray the wall with a little bit of indigo carmine and put some secretin if we have it. It's variably available, but that's one trick to visualize an invisible minor. And then I would use a small caliber sphincterotome and a 021 or 018 wire. That's the only place for thin wires in my activity. Then I would put the tip of the wire out of the catheter a little bit and try to sort of hook myself into the minor with that. I think those are my sort of number one issues. I would be very reluctant to do freehand pre-cutting of a minor.
So the time has passed. It was a very nice time. We spent an hour discussing about a very fascinating issue of bile duct cannulation. And at this moment, I would like to thank you very much. It was a real pleasure to enjoy your presentation. We enjoyed the one-man show. It was fantastic. I think all the attendees appreciate that. And just for the information for all of us, it's the recording of this webinar will be posted on the e-learning section of the EAGA website. And there at this place, you can find also the previous webinars. And if you have not seen them, please check them out there. And then I would like to, this moment, thank the governing board of the EAGA, which gave us the opportunity to have this session. And of course, my webinar team, Claire Gay, David Inker, Maria Esguerdo, and Veronica Bonalumi for helping us to make this session true. And for the future, we have next week, we have a Fujifilm sponsored webinar, satellite webinar, as we say, and also for on July 18, we have another sponsored webinar by Alpha Sigma. Please mark them on your calendar and try to watch them. It will be fascinating webinars as well. And before saying goodbye, I would like to say thanks to our partners, premium partners, major partners, general partners, for giving us the opportunity to run all these educational activities with their continuous support during this challenging time due to the pandemic. And at this moment, I would like to thank you everybody for participating and wish you to enjoy the rest of the evening. And until the next time, au revoir. Bye-bye.